Elaine, please.
Sure. So hello, everyone. Thank you so much for joining us this afternoon for the Community Health Worker Financing Webinar as a follow-up to the meeting at CDC in May. I'm Elaine Arkin. I'll be moderating the call today. But first, I'd like to turn it over to Betsy Rodriguez, who will provide a welcome.
Thank you, Elaine. Welcome, everyone, and thank you for joining us in today's webinar. You all know me. My name is Betsy Rodriguez, and I will be your host today. And Elaine will be our facilitator. You know her very well from the forum. In today's CHW Financing Webinar, we will have 4 speakers: Megan Sanders, Carl Rush, Deidre Stockman, and Charlie Alquero. You know the first 3 speakers, and for Deidre and Charlie, first, thank you for being with us today, and allow me to share some highlights about them. Deidre Stockman is the lead for the secondary prevention in the Division of Quality and Health Outcomes in the Centers for Medicaid and CHIP Services at the Centers for Medicare and Medicaid Services, CMS. In this role, she works with states and public health partners to improve delivery of preventive services and health outcomes among people enrolled in Medicaid and in CHIP. Charlie Alquero is the Executive Director of the Southwest Center for Health Innovation. The Southwest Center for Health Innovation is a nonprofit organization focusing on community health. Their mission is to develop and implement policies, strategies, and models in underserved and underrepresented populations at local, state, and national levels to improve quality of life, health status, and equity. The speaker bios are included in the handout section in the system. Also, I'm not so sure if, yes, it's with us. Sarah Klein from Editors. She's an editor from Transforming Care, is our special invitee as a participant. Carl talked to us about her, and we're so happy to have you with us, Sarah. So then here in the slide you can see something that I thought that it would be nice to use in our webinar today. When the word says give up, hope whisper, try it one more time. Never give up is what we all say, but don't just say it. Let your actions speak louder than your word. You ask and we listen. This webinar is part of the conversation we had in May. We do not give up. We are here to keep talking and to keep listening. This is what this webinar is about. Next. Now, without further ado, I would like to turn the time over to Elaine, who will be our moderator for today. Thank you, Elaine.
Thank you so much for those inspirational words, Betsy. And let's just start out, everybody, with just to quickly go over the agenda. As Betsy has already mentioned our speakers, the topics for our speakers include community clinical linkages and CHW financing. That's Megan Saunders.
Your conference is being recorded.
And hello.
Yes,
followed by an overview of financing approaches from Carl Rush, elaborating on what he told us in May. And then Deidre Stockman will be talking about Medicaid and CHW financing opportunities. And then Charlie Alquero has kindly offered the New Mexico story for financing CHWs, which I've had a little preview of it. It's quite wonderful. So that's a lot to pack into an hour and a half. And so here's what we're going to do. We hope that you do have questions for our speakers. And if you do have any questions, as you're thinking of them, if you would enter into the chat box that you can see just to the right of the slide. We'll be tracking those questions, and as you can see on the agenda, following all speakers, there will be a Q&A session. in any case that we can't get to all of the questions, we'll do our best to answer them by email afterwards. But please do ask questions, and we will get to them. You'll see at the end there's also a little bit of time for any comments that any of you who are participants might want to share with everyone before we sign off. And again, if you would like to, I'll just call out for anyone who would like to contribute a comment. If you would then put your name in the chat box, I'll call on you. So this is pretty informal. Please do stand up and stretch as we're talking if you'd like, and we just want to make sure that you are comfortable. A couple of other housekeeping items here. This is the webinar, as you've heard, is limited to participants and CDC staff who were at the forum, except for Sarah Klein from the Commonwealth Fund, and we're delighted to have her, have you join us, Sarah. As you've already heard, the webinar is being recorded, so it can be made available to later if there's some people who are not able to join us, or if you would like to share the audio recording with others, I think that that will also be possible. You can also find a number of items in the handout sections on your screen that you can pull up or print off for later use. And then I think that's it for the logistics. Do let us know if you have trouble hearing anyone, and I will apologize in advance. In Arlington, Virginia, we're having a very violent storm, so you may hear a little bit of static that hopefully will go away soon. So today we will be discussing CHW financing options available through Medicaid and other mechanisms. And also we'll hear examples of approaches states have taken for financing CHWs through Medicaid and other ways. And we'll also hear about action steps that CHWs and CHW allies can take to work with states on CHW financing efforts. And not here, but vitally important, is that we also will have an opportunity to hear questions from you and ask our speakers to help answer them. So just before we get into the speaker presentations, a quick recap of a couple of things that we heard at the forum, just to get us all back in the groove here. The first is that financing encompasses not only reimbursement of CHW services, but also funding for professional development and efforts to develop CHW organizations and networks, including establishing and supporting a national CHW association. We also heard that existing financing options tend to cater to CHWs that are operating within the medical system, while sometimes those working in community-based organizations or settings might be overlooked. And while some CHWs at the meeting felt that existing financing and reimbursement mechanisms, including those that were discussed at the forum, were good news for those operating within the medical system, they did feel that some of what they were hearing was not relevant for CHWs and CBOs. So compensation was a specific aspect of concern relating to CHW financing, and participants expressed a need not only to address how CHWs are compensated for their work, but also to determine what value should be placed on the work in terms of salaries and wages. Just a couple of more points. Engaging payers and conversations about compensation was considered an important next step. One participant noted that payers are interested in how to stretch the money they pay on claims to address social determinants of health. And CHWs are uniquely positioned to help with that. And if someone needs you, you have more bargaining power. So that was definitely a message point to use. And then there was also a sentiment to encourage agencies to work together to identify innovative ways to blend financing into a central stream that could fund CHW programs to work across silos, including different disease conditions or disease prevention programs. So that's just a quick recap. I'm sure you'll be hearing more soon. But with that, I would like to turn it over to Megan.
Thank you, Elaine. Good afternoon, everybody. I hope you can hear me okay. My name is Megan Saunders, and I wanted to spend a few minutes, maybe about 3 or 4 minutes, talking about community clinical linkages and how that might be important in CHW financing. Next slide, please. For years, we know that CHWs have been working, as you see the little man moving across the clinic to the community. We know that they're ideally positioned to be the best connector between the priority population in the clinical and the social or community setting. Healthcare providers and CBOs and a CHW can work seamlessly to both meet the social and clinical need of a patient. So community clinical linkages are connections between community and clinical sectors to improve health outcomes, to improve population health. And we see the CHW as the best example of how to do that. Next slide, please. I think I'm speaking to the choir about who is a CHW, but a CHW is a trusted member or somebody who's unusually close to understanding the community they serve. Years ago when I worked in dengue, once I knocked on somebody's doors in the hills of Jamaica, they knew who I was because I lived in the community. The most importantly, as it comes to regarding community clinical linkages, a CHW serve as a liaison or a link or an intermediary or a bridge between the health and the social sector and the community. And because of that, they increase access to care, they help to improve the quality and cultural competency of the service that's being delivered, and they build individual and community capacity, which is something that we need if we're going to sustain CHW work and finance them. Next slide, please. So why is it that we care about the community guide, and why is it that we know it's important to have evidence that there is proof that a community worker is effective in what it does? The community guide, as you know, is an independent, non-federal group of panel of about 15 public health and prevention specialists from all over the country, and they provide evidence-based findings and recommendations to improve health. Their big focus, of course, is on population health interventions in community and healthcare system, and they are a very credible source of information and looks at systematic reviews and findings and then provide recommendations for the nation as a whole about what to do around specific areas. I was excited, can you move on to the next slide, please, to recently work with the community guide to develop and look at systematic reviews that led to them giving recommendations around the role and effectiveness of CHWs. As you can see from this slide, I think one of them is out of place. The CHW model of care looks at about 5 different roles. They're a member of a healthcare team, so they're part of this team-based care approach, which is a part of the value-based system that we're moving into. They serve as health educators or screeners. They work in outreach, or enrollment, they're navigators, or they're community organizers. Can we move on to the next slide, please, which I think should pick up on community health, the community guide, sorry. One of the things that was very exciting about the community guide's findings on CHW is that they made a recommendation in March of 2015 that engaging community health workers for cardiovascular disease prevention was an economic recommendation because it was economically effective. It was also, of course, cost beneficial to have CHWs enroll in this work. In addition, in August of 2015, their recommendation for interventions engaging CHWs for prevention of type 2 diabetes was released, and that showed also that the use of CHW was cost effective. And you have the slides, I won't need to read it to you. And last but not least, on the last bullet, the guide recommended that using or engaging, and I'm sorry for using the word using, engaging CHWs in prevention of type 2 diabetes was strongly recommended because it was an economic recommendation, because it was cost effective and cost beneficial to have CHW, especially in priority populations. So the community clinical linkage that a CHW can perform by moving between the clinical sector and the community, including the work in public health, is critical for our consideration if we're going to get to financing of CHWs. We know there's no magic bullet, and you can move on to the next slide, please. And so there's lots of work to do, but there's lots of resources. I just listed a few here. Just wanted to sort of touch the tip of the iceberg and mention community clinical linkages, and to also share with you that we have developed a guide that addresses this work, because we understand the critical need for some resources that can actually help you to explain to CBOs or your employer why you need to have CHWs financed. And so with that, I turn it back over to, I think, the first speaker, which is Carl, and I'll be here for questions. Thank you so much.
Thank you so much, Megan. And Carl, I will turn it over to you. Carl, you may be on mute.
Indeed, I was. I'm going to move through this quickly, partly because you heard from me at length on this. I'm going to dig a little deeper into a couple of issues, but also to give my fellow presenters their due. You have not heard from them, and what they have to say is extremely important. So I'll be looking at a few of these issues. It is important in public health and healthcare that most of the time when folks are talking about financing, it's about programs or services. They're really not talking about financing specific personnel. So our conversations about financing CHWs is pretty unique. It's also important to remember that financing is related to all kinds of areas of policy and systems change, is highlighted on in the bullets under that point. And that we did talk in the May meeting about financing workforce development. That is also extremely important. But it is, I want to reinforce the point that for most professions, workforce development is about meeting the anticipated demand for hiring members of that profession through training and recruitment and so on. In case of community health workers, it's also important that we're working on stimulating demand. We're working on making it possible and desirable for employers to hire more CHWs. I touched on this a little bit in May, and it's I'll gloss over it very quickly, but in healthcare reform, the players in the system are looking to do some things they don't really know how to do very well. And all of the points on the slide are things that are extremely important capabilities that community health workers bring to the healthcare system. And the transition or the connection between this and community health is through the discussion of population health and social determinants of health, in which community-based organizations also play an extremely important role. And community health workers operate in both within healthcare and within the community-based sector. The other really favorable trend, which we've touched on before, it's worth repeating, that the payment for healthcare is changing. And so in a lot of ways, I encourage folks to resist the temptation to talk in terms of reimbursement, because even though there's still a lot of fee-for-service payment going on, it is changing. And the new models, and we'll hear some more about this in the later presentations, but in the new forms of payment, they have a lot more flexibility to staff the services that are provided under those payments. And the shared risk or shared savings value-based payment systems, and there are a lot of different forms that may take, those provide the greatest degree of incentive to providers to engage community health workers in improving the health status of populations, making systems more inclusive, more responsive to the needs of the priority populations that they are serving. So there are things that are changing that are important. So when we're working with payment mechanisms, there's several things we want to touch on here, and you'll hear more about that later this afternoon. That there is policy level change taking place at the state the state Medicaid program level in terms of waivers and state plan amendments. There is also a considerable amount going on among managed care organizations in states, and there's still states that are in the process of converting from fee-for-service to managed care, but that there's plenty going on among managed care organizations paying for community health workers as an administrative cost because it is to their advantage to do it. And as I said in my earlier presentation, where there's a will, there's a way. Where health plans and providers see a need to include community health workers in what they do, they will find a way, and they are finding a way. And so it's not like we don't see anything going on. There are indeed healthcare providers who are simply seeing the logic of employing community health workers out of their core revenue because it improves their results and it improves their cost picture. And then we did talk last time, we won't spend time on it today, about the qualified health centers who still, for the most part, are paid under what they call prospective payments. And the big issue there is that they are paid per encounter or per visit, but only visits that involve contact with a clinical professional count as an encounter. So a home visit by a community health worker by itself is not billable for these health centers. So there is a need to make some explore some new options with them. I mentioned Medicaid administrative costs. They have a lot of flexibility to do this. Many of them are doing it now. There was a change in 2017 at CMS in which certain quality improvement efforts, the cost of certain quality improvement efforts, can be considered part of the cost of care. And it is very clear that in some states, there are examples of some states where community health worker efforts are considered part of quality improvement, and that is an avenue that is already open to us. Then we have the outliers like Pennsylvania, in which their Medicaid program simply allows the health plans, whether they employ CHWs directly or pay providers or CBOs to employ CHWs, that they can treat those expenditures as part of the cost of care now. There's no red tape involved in it. And the state and the health plan seem to be very, very happy with that. So there are some creative examples out there, and I'm sure Deirdre and Charles are going to be addressing other specific examples, but Oregon now has a system of accountable care organizations they call CCOs, and they require that certain the services of certain traditional health workers, including CHWs, be made available to their members. Rhode Island recently implemented an asthma home visiting model as part of the core benefits of Medicaid. And those, in most cases, through organizations like Neighborhood Health Plan of Rhode Island, the asthma home visiting is led by CHWs. There are a bunch of states that have state plan amendments to create health homes, which are essentially medical homes for folks with complex needs, commonly including behavioral health issues. And a bunch of the states that have those state plan amendments use that structure to employ CHWs. There's several states that are listed there that are doing that. A very unique one in North Dakota is a state plan amendment that authorized payment for tribal community health representatives to provide targeted case management services under Medicaid. And that is a significant breakthrough. It's very recent, but hopefully will have some implications for other community health workers within North Dakota. And then Indiana, as of July 1, announced that they were going to treat community health workers as a class of providers, similar to the way they've done it in Minnesota, with a limited set of billing codes that can be used. But this was an interesting situation in that I have not been able to find any record of a state plan amendment in which this was authorized. I'm still trying to find out how they did it, but they announced it with great fanfare in June. I mentioned briefly in the May gathering that employers and payers have occasionally said, look, we're just going to bite the bullet. We're going to use our core budget. We're going to find a way to pay for community health workers out of our core budget. And these are examples that are familiar to a lot of you. And this was an initiative that you'll hear more about from Charlie, originated by Molina Healthcare, or financed by Molina Healthcare. And they saw fit to do that for the benefit that they anticipated from it. And it has paid off. Texas hospitals, the safety net hospitals, because of continuing high uninsured rates in Texas, have found that they can improve the cost of care for uninsured individuals, the cost of uncompensated care, by having community health workers redirect folks from emergency departments into primary care. And then lastly, a private industry example, a self-insured employer who paid for a worker who helped to coordinate care for the employees who were costing the most to the health benefits program of the company. I mentioned federally qualified health centers. Just to restate very quickly, there are very few on record as being employed in community health centers, and that is of some concern to their national association. And an interesting variation on this, the last bullet on this slide, is that in the financing that health centers get from the Health Resources and Services Administration, from the Bureau of Primary Health Care, they allow a category of expenditure called enabling services. And there are health centers out there who pay for community health work through that source. Well, I have asked the question kind of rhetorically, if Medicaid will pay for, and states at least currently are required to pay for non-emergency medical transportation, why not extend that category of expenditures to something like what HRSA provides for with health centers, a category like enabling services, which would enable providers to, or health plans, let's say Medicaid health plans, to pay for an array of non-clinical services that improve access to care, that improve adherence to treatment, that improve appointment keeping behavior, a variety of things like that, that can help the system provide better care. So that is at this point still a rhetorical question, but an interesting one in my opinion. So lastly, I want to say that when we're talking about financing, there's kind of an arc that we follow, and this is extremely important. We cannot afford to neglect the issue of awareness and education for potential employers of CHWs. And I'll let you spend time on this when you get the final slides following this webinar. But there's a process that we follow from the basic issue of awareness, and we are still finding it to be the case that many stakeholders, including potential employers of CHWs, simply do not know who community health workers are and how they function, and how they can benefit them, which is clearly the bottom line. And so they need to follow a kind of stages of change process from being aware of community health workers through recognizing the salience, or recognizing how community health workers relate to their needs, recognizing through the business case or the value proposition how community health workers add value to the system, and then getting them past the point, usually helped along the way by internal pilot programs or projects within their own organization, or at least within the same state, showing them how it works for them or for organizations like them. Only then can they get to the stage of a commitment to say, okay, yes, we're going to do this. And ultimately, you would like the employers then to follow through by way of helping you to advocate for policy change and importantly, as champions, helping to persuade other employers. So I think that this is something we always need to continue to come back to. So I think I've completed within my allotted time, and I would like to turn this back then to our moderator. Thank you very much.
Thank you so much, Carl. Indeed, that was timely and really helpful, and that last figure is something that I think we can all refer back to. Just a reminder to everyone, if you have a question for Carl or for any of our speakers, please do enter it into the chat section, and we'll have a chance to address those questions after all of our speakers have presented. At this point, I would like to turn this over to Deidre for our next presentation.
Great. Thank you so much, Elaine. And thank you all for the opportunity to join you today. I understand there's a little background noise where I am, so I'm going to try to speak loudly and clearly and also move through my slides quickly so that we can get to make sure to have plenty of time for discussion today. So I'm going to go a little bit, in some ways deeper, but in some ways broader and higher level than some of the things that Carl just shared to kind of give everyone a little bit more grounding in the opportunities that Medicaid provides for paying for services delivered by CHWs. So my two probably most important points are on this slide. So if you need to leave after that, you can, but I hope you'll stick around for some more examples. But the first is that the most important point is that there are multiple authorities under which community health workers may provide services to Medicaid beneficiaries. Is someone trying to stop me?
No.
Okay. Okay, I just heard a little feedback.
Yeah, just a reminder, everyone, just a second, Deidre, if you are not speaking, if you would kindly put your phone on mute, as well as mute the speaker if it's at the top of your screen. If it's green, if you'll click on it, it will turn gray. I'm sorry to interrupt you, Deidre, but maybe that will help.
No problem. Thanks so much. Okay, so back to the two key points. There are multiple authorities under which community health workers may provide services to Medicaid beneficiaries, and Carl mentioned a number of them and gave you a sense. I think it sounds like many of you probably have a sense that there are lots of different ways to get there with Medicaid, and that there's no one policy regarding CHWs in Medicaid. Instead, there are lots of different options for states. And so that leads to the second key point, which is in order to gain Medicaid reimbursement for services provided by CHWs, it is just absolutely essential to work closely with your Medicaid agency to explore the options that are available in your state, and really to build a partnership to understand not only the Medicaid landscape, well, to understand the sort of Medicaid policies and the broader landscape in which Medicaid is functioning within a state. As I think you all know, Medicaid varies from state to state, and the program is administered by the states, which leads me to my next slide, which is just a high-level overview of Medicaid for level-setting purposes. So as I think you probably all know, Medicaid provides health care coverage to more than 74 million low-income children and adults. It augments Medicare for more than 7 million elderly and disabled individuals. And the program was enacted in 1965 and has, of course, evolved considerably over the decades since then. Medicaid is a partnership between the federal and state governments. So states administer the Medicaid programs within their state, working within broad federal frameworks. And state and federal governments share the cost. So in most cases, you're probably aware there's a federal medical assistance rate that is negotiated for each state. It varies slightly. Usually the federal government pays a little bit more than half of the cost of the Medicaid program, but it varies from state to state. And within broad federal guidelines, each state then operates and administers its own program using a state plan. The states establish their own eligibility standards again within the rules, determines the type, amount, duration, and scope of services that are covered in the state Medicaid agency and for which enrollment groups, and sets the rates of payment for those services. So all of those are state level functions. So the Medicaid state plan is I'm going to focus on some of the Medicaid state plan authorities that are available for covering CHW services. The Medicaid state plan is the state's contract with CMS to administer the Medicaid program. It describes who is eligible, what services are covered, what medical services are covered, which providers can be reimbursed for providing those services, and how they're reimbursed, so the methodology for reimbursement. State plan amendments are necessary to make any changes to eligibility or coverage or reimbursement or any other section of the state plan. So I'm going to talk about a few common options, but that are by no means exhaustive. Again, going back to my first and the most important point, that there are multiple authorities. I've highlighted in the next few slides some of what we think are probably the most common, but I'll also touch on afterwards some of the ones that Carl alluded to that I haven't mentioned here in the slides. But here we've pulled out, talking with some of my colleagues, where we think are some of the most common state plan authorities under which CHW services could be covered. But again, this is not an exhaustive list. So one state plan authority are other licensed practitioners. And this is applicable if your state or the state you work in license CHWs, or if your state recognizes CHW certification as equivalent to licensure, or if CHWs are supervised by another licensed practitioner. So there are a few different ways that CHWs can fall under the other licensed practitioner section of the state plan. Carl referred to Minnesota, and it sounds like Indiana, which I'm actually not yet familiar with that example, so I'll do a little digging if I can find out more, but it sounds like potentially Indiana has just recently possibly used this authority to cover services provided by CHWs. So under this benefit, CHWs can provide any service that's defined in their scope of practice according to the state's scope of practice law. So you all may be familiar, the state scope of practice law is broader than Medicaid. It applies to the scope of practice for all types of practitioners or a variety of practitioners within a state. But if this authority is used, then it refers back to the state scope of practice law, and CHWs can provide anything that's defined there if this option is used and applicable. A second state plan option, which there was a lot of excitement about, but not a ton of action on yet, but I think is particularly applicable in the diabetes prevention space, which I know many of you are focused on in part, is the preventive services benefit. So under the preventive services benefit, unlicensed practitioners, it can be included, who are subject to qualifications established by the state, may provide preventive services to Medicaid-eligible beneficiaries based on a recommendation from a physician or licensed practitioner. Preventive services, regardless of who they're provided by, must be medical or remedial in nature, and services must involve direct patient care and be for the express purpose of diagnosing, treating, preventing illness, injury, or other impairments. It's a broad definition. The Medicaid definition of prevention is quite broad. But it's important to note that non-medical preventive services that address broader social or emotional or environmental or emotional concerns cannot be covered under this benefit. Most of what I'm talking about here are medical services because Medicaid is a program that pays for the delivery of medical services. It's a health insurance program. So I think diabetes preventive services may be provided under this, well, I know diabetes preventive services may be provided under this benefit. So examples of diabetes preventive services include screening for elevated HbA1c levels or other diabetes risk factors, counseling for physical activity, counseling for nutrition and diet, the types of services, for instance, that are delivered as part of the diabetes prevention program. And here I'll just take a minute for those of you who are involved with and very familiar with the diabetes prevention program. As a program, Medicaid, the way it's structured currently, is that Medicaid pays for medical services. And so even if the payment arrangements are not fee-for-service, the services delivered still have to be defined. So in general, we say Medicaid does not pay for programs, it pays for services. And if a state wants to reimburse for a program such as the National Diabetes Prevention Program, Lifestyle Change Program, the services that are provided, the medical services that are provided as part of that program need to be defined. The state plan option 3, which is a huge option that Carl also alluded to, is Medicaid managed care. And as Carl noted, and it sounds like many of you are probably familiar, Medicaid managed care provides for the delivery of Medicaid health benefits and additional services at their option through contracted arrangements between state Medicaid agencies and managed care organizations. And they're administered through a set member per month or capitation payment for those services. In many cases, managed care organizations provide additional services and or engage additional provider types beyond those who are described in the Medicaid state plan. The services described in the Medicaid state plan is the floor, provide the floor for what is provided by managed care organizations, but as Carl has alluded to already, managed care organizations have a lot more flexibilities to cover other services out of their administrative or out of their own profit dollars and work with other providers beyond those covered under the Medicaid state plan. So there's an enormous amount of flexibility under managed care. An important thing to note is that there are a few different ways, and we don't need to get into the weeds, there are a few different ways states can opt for or administer a managed care program. There are state plan authorities. There's also waiver authorities for doing that. Regardless of that, one challenge that we have here at CMS, or kind of a blind spot, is that because there's a lot of flexibilities, we don't hear everything that managed care programs are doing. We don't kind of have any reporting mechanisms. I am sure that there are lots of managed care organizations that are employing CHWs that we haven't heard about. Carl may have heard about them. You may know about them. I don't necessarily know about them. But that because there's a lot of flexibility, but there's not a requirement to report on all of the ways that MCOs are using those flexibilities back to us, which is fine, but it just means that we certainly do not know all of the different ways that CHWs are being employed and used in partnership with managed care organizations. So I didn't include a slide for health homes, and maybe I should have as I thought when Carl mentioned it. The health homes is another Medicaid state plan authority that provides for very comprehensive and integrated care for people with chronic conditions, multiple chronic conditions, or a single chronic condition who are at risk for another chronic condition. And the health homes authority allows for payment for services such as connecting individuals to social services to address some of the social determinants. So there's a little bit more kind of flexibility or care coordination payment available under health homes that can be a good fit, but the health homes model is by definition an integrated multi-provider model for addressing one or more chronic conditions that the state has to define. So CHWs can absolutely be a part of the care team delivering services under a health homes model, and I do think we have a handful of examples of that going on as well. So to conclude on some key considerations that I have already mentioned, and I will mention again, it is absolutely essential to work in partnership with the state Medicaid agency to understand the state Medicaid context and to explore the potential opportunities. I encourage people, I do a lot of work with Medicaid agencies and public health agencies working together, and very much encourage approaching that conversation open to hearing about and kind of solving the problem and finding the right course together rather than approaching it with having all of the answers. Because there may be things that your Medicaid partners know that you don't know yet. So working together to figure out the best way, like Carl said, if there's a will, there is probably a way in Medicaid, and working together is going to be the way to figure out what that way is. And so a couple of things to consider that you all could bring to discussions with the Medicaid agency include identifying what those Medicaid-covered medical services that CHWs provide are, identifying the qualifications that CHWs have to provide those services in your state, and being able to really describe the benefits of having CHWs provide the services. What are the cost savings? What are the improved quality opportunities provided or that CHWs can offer to a Medicaid program or to a Medicaid managed care organization? So let me stop there and hand it over back to, I've included a few resources here in the slides, and we'll keep moving on or go backwards. I'm not doing that.
That's okay. That's all right. Well, we can fix that. Not a problem. So thank you. That was fabulous, Deidre, and especially your suggestions at the end about what we can do to prompt some additional connections with the state Medicaid offices. So it was very useful, and I wish you had that one on a slide. So if anyone has a question for Deidre or any of our other speakers, please do put it in the chat box. And with that, I will turn it over to Charlie.
Hi, thank you very much. So I'm going to tell you a little story about the New Mexico experience in CHW financing. It's been going on for a while, our efforts to try to establish a solid delivery and payment system through which community health workers can be assured ongoing support of their families through gainful and stable employment. The program we're now calling CHW Leads, we formerly called IPACS, and it doesn't really matter what the acronym means because we're not calling it that anymore. But it's a program that's developed between the Human Services Department Medicaid program in New Mexico, University of New Mexico Health Sciences Center Office of Community Health, and the Southwest Center for Health Innovation, which is formerly a division of a community health center in southwestern New Mexico called Hidalgo Medical Services that I helped found about 23 years ago. Over the course of time, it became clear that as we were developing services in very frontier areas and trying to do comprehensive health care, that we needed policy input at various levels of government, and that our unique needs required local evaluation, research, and advocacy for the things we wanted to do. So one of the things we wanted to do was improve health of our population through community health worker work. We've been working for many years. In fact, our initial staff of 4 at Hidalgo Medical Services included a community health worker in 1995, working on a contract with the Department of Health for diabetes services. But over time and through the CDC REACH program, we expanded and enhanced our thinking about community health workers in collaboration with the University of New Mexico, who was our contracted evaluator for our REACH program. We started thinking about community health worker services in the way you're looking at, and that is there's sort of a large enough population, you have a bell-shaped curve of health. However, consistently across that bell-shaped curve, there's a cost curve, the dotted line, and as people become more ill, their costs go up naturally. And that prevention alone was not necessarily the issue, and sort of categorical approaches to health touched the surface of health improvement, but really didn't address the full needs of families and the healthcare system to save costs and improve health. So We started focusing on intensive patient support services, care coordination services, and I'll talk about more about that in a minute. And as we became successful in saving money, we said, well, what should we do with this savings? It's obviously not going to go back to taxpayers. It's not going to go back to the state government. It stays in the MCO's hands. So let's figure out a way to move that money further upstream, support clinical preventive services enhancements, and then ultimately community health improvement strategies. So there's a little timeline about how we got started with our initial funding for community health workers through REACH, sort of expanded funding. We also, during that period of time, 1998 to 2010, had NIH support looking at cardiovascular disease with community health workers and had good success in those outcomes as well. In 2010, we started the Molina MCO contracting. And part of my discussion is to talk about how sort of volatile and ever-changing the Medicaid environment is. So we had these great contract with Molina for New Mexico, and in fact, Molina's central office contracted with UNM and us to develop a national training tool for Molina in the 9 states at that time that they were covering. And what they did with that information in the other states and to some degree in New Mexico was centralize community health workers at the insurance office level using 800 numbers to serve patients at the community level. In some cases, there were regional representatives put in communities, but not attached to the healthcare system, not attached to primary care, and working independently as community health workers. In 2012, we started working on Medicaid contracting to define models, and we've had various contracts over time with MCOs, but it's an ever-changing playing field. The state contracts with MCOs are 4 or 5 years. Every year there are updates to those contracts that change and change priorities for MCOs. And the primary driver of MCOs, in my opinion, is market share. So if you don't have that Medicaid eligible person in your MCO, you don't get a PMPM for that person. So it's important for MCOs to have a unique service line and are very unlikely to want to have standardized approaches across MCOs because it doesn't provide them the distinction necessary for consumers to make informed choices for them versus another MCO. So that's been very difficult. It's sort of overcoming, trying to develop standardization of our modeling and payment system while trying to overcome market share issues. During this last few years, we've also conducted several social determinants of health studies at community-based health centers and UNM, and had some interesting outcomes about what people believe priorities are. We've had some community interventions around sliding fee scale for utility payments because people claim in their assessments, WellRx assessments on social determinants, that utility is a major issue. I'm going to move on. I'm running out of time quickly. In our model, we took the components of our intervention strategies and compared those to the components that people have been measuring patient-centered medical home effectiveness by, and we're using the same criteria for patient-centered medical home savings. We apply that to what we were doing with CHW, and this graph shows you a large amount of difference in what the potential savings are in PCMHs versus comprehensive CHW. There's 4 parts basically to developing the model in our perspective. Our state and a lot of people have been focused on training and certification concepts, and we've been focusing on finance and delivery issues. I mean, they're all ultimately integrated, but oftentimes I think the cart is put before the horse in states and in their efforts to obtain certification and training programs that ultimately lead to certification or licensure. CHWs without there being a financing mechanism that's adequate to support them once they become certified or licensed. So we focused on certifying programs through contracting rather than individuals. And so when we say program certification, that an MCO will provide the contract, accept the contract, and the provider organization will certify that they will meet the terms and deliverables in those contracts and the outcomes that folks have agreed upon. Our really key concept in our financing model is that it is not to be part of the medical payment system, that it does not require an interaction between a provider and a patient in order for there to be compensation, in that we feel there's demonstration enough of the value of CHW services that there's incentives enough to contract for those services specifically, that there's no need for it to be part of that. And also it provides community health workers with a certain equity position within organizations if they have generated specifically for their services and not incidental to a medical encounter. So currently, as Carlos pointed out, there's a variety of ways in which community health workers get paid or are compensated, or organizations get compensated to pay community health workers, grants and contracts, foundation grants, general operating dollars like UPS, things that Carl was talking about earlier. And these contract grants, CPS decisions are all time limited and discretionary. They don't ingrain or institutionalize the concept of community health worker services as a valuable component and fixed component of the healthcare system and are subordinate in terms of the position of CHWs and the rest of the organization. In our model, we're again trying to say that fee-for-service is not a desirable approach. High volume, low quality incentives and fee-for-service. The same with sort of a cost-based reimbursement, where you come up with a fixed cost of a program and spread that across the number of users of the program, and it doesn't allow for individual and in fact discourages treatment of high needs patients because of the fixed cost nature of cost-based reimbursement. What we do feel is desirable, consistent with what Carl was saying earlier, are budgeting models, risk-adjusted sort of PMPMs, bundle payments, and we're not including value-based payments in this. I'm not including value-based payments in this, or PCMH add-ons, because again, they are incidental to medical practice concepts, and in fact, community health workers, a lot of them are not focused on clinical intervention strategies, rather helping people and families determine what's best for them in terms of health outcomes. And that's been, again, a real challenge. Right now we have almost all of the items in the box on the right covered in our dissertation. And so we're looking forward to another year of contracting with our Human Services Department. We're meeting with them Friday to continue on the contract. We've changed. One of the problems I mentioned earlier is the MCO environment. This year, New Mexico has 4 MCOs. 2 of them will be gone by the end of the calendar year, and we'll get a new one. So we'll have 2 MCOs that we have historical relationships with and 1 new MCO. And 2 of the ones we currently have contracts with for direct service models are going away. And that's a challenge in working at the state level and coming up with consistent. Here's my contact information without my phone and email, but you can get that through the office, I'm sure. Thank you.
Thank you so much, Charlie. That was very helpful, as have all the presentations been. And so a reminder, if you would like to ask a question of any of our speakers or anyone from CDC who is on the phone, please do enter your question in the chat box. And speakers also, if you would have comments on what you have heard from other speakers or anything you would like to add about your own presentation, please let me know that as well. And actually, there is a question for Charlie. Can you give some examples of the services that are being provided in New Mexico?
Yeah, I think, so one of the concepts is in fact working with social determinants of health. And so in those primary care link strategies, applications are referred from clinical providers to community health workers for follow-up, and there's in some of our contracting 100% touch rate with that, with patients and community health workers. There's an assessment done of social determinants of health, as well as ACEs, and so part of the care plan for patients includes addressing social determinants of health, which community health workers work on. You know, there's also, in our model in Hidalgo Medical Services in Silver City, we have a fully integrated health record with behavioral health, dental, primary care, community health workers, so that there can be electronic referrals, electronic follow-up, and communication right within the medical record electronically, the status of social follow-up issues and those kinds of things. And another thing we're working on based on a request from the state is jail diversion, post-jail intervention strategies with community health workers as people reintegrate and become Medicaid eligible. What are the infrastructure needs in their lives that they have so that there won't be a recidivism around jail issues? So there's several different models that we're working on.
Great, thank you, Charlie. And anybody want to add on from your own experience of any other examples of social determinants that have been covered?
Elaine, there is a question from Leticia.
Yeah, I was just saying if anyone wanted to follow on to Charlie's good examples first. But we can certainly move ahead from, where did Leticia go? Hold on. Oh, there. This is for Deidre. Is there a single document that lists all the authorities under which CHWs can provide services?
So the answer to that is no, there isn't. And the reasons are a few. The first reason the main reason is because there are so many different options that I don't think anyone here at this point in time, given that there's still kind of a lot changing in the field of CHWs and in their employment under, in Medicaid or, reimbursement through Medicaid, that I don't think anyone would feel comfortable claiming that we could make a complete list, because of the variety of options. And so that's why my main and most important message is that you're going to need to work with your state to figure out what the best options are within the state, and that'll help to narrow down those options. But I did list what I think are a few of the most common, and then would add on the other authorities that Carl mentioned, including health homes, which is a state plan authority, targeted case management, which is a state plan authority. Waivers are obviously, by definition, beyond state plan, but not necessary for the coverage of services by CHWs, but another option. But again, I would not claim that to be a complete list. So the most important thing is to work with your state to figure out the best options.
Great, thank you.
And let me just quickly add to that. I say that because your state Medicaid colleagues are really the experts in how Medicaid works in your state. And if they have questions or are not expert in any particular authority, they know who at CMS to ask. And there are kind of regular channels established for that purpose, and it's best to work through that process to get to the best answer in any given state.
Great, thank you. And this is a question for any of the panelists, and the question is, what is the most significant barrier you've seen related working with MCOs on the inclusion of payment for CHW services?
This is Megan Saunders from CDC. Could I maybe Can you hear me, Elaine?
Yes. Go right ahead.
One of the, if you don't mind, I'd like to just share a little bit from the CDC's perspective on that question. We have funded states to do work with CHWs for several years now. In fact, I think this is my third or fourth FOA or grant that we're working on with this topic. One of the things we found as we've looked across the country collectively is a few things. There is a lack of understanding of the role of public health in this space, and then often a lack of political will, because to get to a state plan amendment or a waiver or OLP or any of the options that Deidre mentioned takes a lot of making sure you have the political will, the social capital, and you have the right partners at the table to get to that outcome of reimbursement, the sustainability, or whatever financing or the terms, whatever appropriate terms we want to use. So from the CDC's perspective, that has been some of the issues. Because CHWs are often paid on grants, and then once the grants end, they disappear, there continues to be a need for continuous training, and it's a lot of investment, and some people are getting tired of doing the same thing over and over again. And so as I remind them that because there's no one magic bullet to fix all CHW efforts, they need to take in the state context to assess the CHW landscape in the state, and then to work collectively with the CHWs and other relevant stakeholders to fix or to get to the end goal that we're looking for is going to be critical moving forward. So those are just some comments from the CDC's perspective. Thank you.
Thank you, Megan. Any other speakers want to comment on that? On barriers you've seen related to working with MCOs or working to further CHW reimbursement in the state, at the state level, within a state?
This is Carl. Just briefly, a big one seems to be, and it does vary between states as so many things do, but that they feel like they are right now being buffeted by so many other changes and expectations on the part of the states and pressures from providers and so forth, that they are reluctant to take risk with anything that they regard as sort of unknown territory. There are certain things they're used to doing. They're used to paying for healthcare services, period. They're used to paying for clinical services. And they vary a lot. I mean, some are more adventurous, and some see the connection between what community health workers do in improving the health of the population that they're responsible for. But a lot of them are very risk averse.
Great, thank you, and no surprise.
This is Charlie. I think, I understand sort of why states choose to work with MCOs rather than pay for Medicaid services directly. However, I don't think it's often a responsible approach to financing healthcare because it changes the motivation in the healthcare system, I believe. And as a result, I think we see not only do we have more than 50 different state and territorial approaches to healthcare, we have that times the number of MCOs, and that creates incredibly volatile, unpredictable, unstable for providers to design systems that can help people. And then if you add the private sector models and Medicare to it, it's exponentially more complicated. So I think it's problematic, and unless there's strong language from a state that sort of says we're going to address these problems this way, the opportunity for there to be lots of waste and profit and lack of return on investment for public dollars, I think is a problem.
So are there some ways that you, Charlie, or others who have been speaking can begin to tackle that? It is a complex time. But, are there any little points of light here that we might take hope from, as Betsy's hope slide said?
Well, it's Charlie. I think it's a longitudinal discussion. You have to be in it for the long run. I don't think, a piece of legislation or an intervention strategy is going to resolve this. And, we've been working on this for 8 years, and we've had, models and things come and things go, but we've consistently, I think, over that time been able to improve our 1115 waiver language around community-based care coordination services. We've been able to provide more direction about decentralization of services. We're now in discussions about Medicaid financing rural physician training in New Mexico. And so these things take years. And I think that investment and consistency of direction is really critical.
That's an important reminder for everyone. Yes, somebody wanted to speak?
Oh, this is Emma Torres.
Go ahead, Emma.
Yes, Melanie, I received a letter for, that I needed to fill out but in the letter it talks about me sending purchasing.
Emma, can you approach the phone? We can barely hear you.
I filled out and it's complete for me to send. Doesn't request any of that information. It only tells me or asks me if I have ever had Medicaid, which I haven't. And I don't have. I'm only 1 year old, so I don't qualify. Yeah, because it doesn't say about asking for Social Security or anything, so that's why, I thought, in the letter it says that, they're requiring that, but in the form it doesn't say anything at all in anywhere, right? Check all the pages, it doesn't say that, so I don't want to include information that is not requested.
So, hello. It was a little bit hard to hear you, Emma. Did everybody get that?
No.
No.
This is Carl. I couldn't really hear at all.
Oh, okay.
Emma, you may want to try to use
Type
the
it.
chat box.
So a lady that
So, Emma, would you like to try typing in your comments?
well, that's nice.
Emma, it sounds like you're a long way away from the telephone.
And a little truck, like a white truck on the front or something like that.
I think she may be on a side conversation.
That's your insured individual.
Oh, that.
I was wondering that as well.
Emma? Okay, so let's move ahead to Sherry's question to Charlie. Do you see the potential for value-based financing mechanisms to be social determinants related as well as addressing medical needs? And Deidre, we might ask you the same question.
Yeah, I think can you say that again?
Sure. Do you see any potential for value-based financing mechanisms to relate to social determinants as well as addressing medical needs?
Okay, thank you, Melanie, for calling me back. So then
Yeah,
So this is Deirdre.
your insurance is the insurance that we need to deal with.
Go ahead, Deirdre. You go ahead.
Okay, well, I just was feeling like maybe you were formulating a response and that I'd start out. So I think in some ways the short answer is yes. Value-based purchasing is about paying. So when you're paying for value, you have to be measuring the quality of care and the outcomes in some way. And so I do think that there is, we know there's a shift sort of underway, and there's plenty farther to go in shifting to a healthcare system that pays for value, and part of that is about paying for better outcomes. And so if we're identifying the outcomes that we want to see, the improved health outcomes, for instance, and at least part of payment is based on that, then it's basically incumbent on the providers, the health plans, kind of whoever the players are, to figure out how to achieve those outcomes. And I think we all on the line know that that necessarily is going to implicate helping people address social determinants of health. So I think that's where it comes in, not as much paying for addressing the determinants directly, but paying for the ultimate outcomes that all of us want and value, and improved health, improved functionality, improved ability to work or not miss school, or whatever those outcomes that actually matter to people are. So that's where I see kind of the real opportunity on the horizon, and I hope that we see more movement. It looks like Charlie might want to talk a little bit about how they're addressing that in their 1115 demonstration.
Yeah, I think the 1115 is still in negotiation, but there's a lot of language about paying for care coordination services. And I think if a patient indicates that the primary reason they're not healthy is because they're living in a car, just off the top of my head, then I think it's incumbent upon the health system to try to figure out, how to address that to improve health. Did anybody see the article in the New York Times, I believe it was this last weekend, about Montefiore building apartments for homeless
yes,
and other patients? I think these things are happening because we don't have a social system in the United States, and so we're leaning on the healthcare system to fix social problems. If that's the case, if that's the route we're going to take instead of having a social service system, then I think over time there'll be more and more flexibility about what Medicaid will pay for.
Well, thank you. I think both of you are turning to creative ways to find the outcomes we're looking for, and we certainly need as many forward-looking strategies as we can get. So I want to open it up to the speakers, but also participants now. If there are comments that any of you would like to make to the group, in addition to any final questions, please think of this as a time for comments on anything you've heard or would like for people to hear from you.
I think, this is Betsy, I think that it will be important to highlight some of the takeaways that at least I have been able to get from the presenters today. From Deidre, we heard very good information, but I think that in her last slide, that first bullet, when she says, work with your state Medicaid agency to understand the state Medicaid context and explore potential opportunities, I think that that's a good pearl of wisdom that Deidre shared with us. From Charlie, I get the word persistent. He said it takes more than one to build a village. It has been taking 8 years. Am I right, Charlie? I think that persistent perseverance and looking for thinking out of the box, it's the way to go. Did I hear you saying that, Charlie, in a way?
Yes.
And then from Carr, I think that I'm getting that there are more than one way to skin the cat. There are many things that can be done. There are many payment models that are out there, and it is a matter of getting into the business on how to get paid for the services and the value that CHW bring to our communities. Is there any other takeaways that we can hear maybe from you, Megan?
Megan may be on mute.
I think
Or
she's
not.
on mute. Oh, okay. Any other takeaways from the speakers that you all want to share with us?
This is Carl, very briefly, and this relates to a couple of things. That yes, where there's a will, there's a way, and in the examples you all were talking about, the Montefiore example in New York that Charlie mentioned, it's not clear yet whether the financing system really drove them to do that, or whether they just saw that housing was an important way to get to the health outcomes that they wanted to produce. But I just very quickly, a couple of points that he raised I commend everybody's attention to the diagram that he used towards the beginning of his presentation about the continuum or spectrum of activities that community health workers need to be engaged in, that it's not just about focusing attention on high utilizers, that we need to move the discussion to a broad spectrum like that. And he also pointed out, using the term the cart before the horse, that too much focus on financing or training and certification it's a temptation we all fall into, to focus on those things first. There are a lot of hard issues in design of the delivery system and how it works and that and population health, and that we really need to focus on that. And I just, by case in point, that Minnesota and Texas started out many years ago focusing on one part of the picture, Minnesota on financing and Texas on certification, and nothing changed in either of those states for like 10 years. And so I think it's important to keep that perspective in mind.
Thank you, Carl. That's very helpful. And does anybody else, either speaker or participant, have a last comment that you would like to share with the group?
This is Maria. This is, those of us have been in this for many years. It's almost cyclical in that the discussion keeps coming up in different parts across the U.S. And I love the summary and I love the topics and the variety of the discussion today. Betsy, it would be great if we could have something that comes from your office that would, I don't know how to summarize such deep information, but I don't think that there's people generally, those who want to start new programs or those who don't know anything about it, don't know about the model, don't know about how to integrate it. We have some resources also, but I think it's important to point people in the right direction. And I think if not, then they're going to develop what they want with their perspective, which is not always the most appropriate perspective. So I'm not sure what I'm asking for exactly, except that I wish there was a resource, and maybe that's, and I know that several of us are working with the National Association, and it may be that will be the resource, and I hope there's some support for that in the future. Thank you.
Thank you, Maria. We can have a call at some point next week, and we can continue having that conversation, Maria. I will be more than happy to listen to whatever you have to say to us.
Yeah, and that sounds like, Maria, it would be very valuable because we can't reach everyone who needs to be advocating by webinars and in small groups. So ways to amplify this and keep it pretty simple for people, what they can do is really important. So thank you so much for that closing. And there is a note from Megan, whose line died, and she said a key takeaway that she wanted to add is that a multidisciplinary approach is really key. And I think that's a good point. We have been hearing that as well. So I know we're right at the end of our time, and gee, I think we could go, have a full discussion right now, Betsy, but thank you so much for those. Yeah, I'm going to turn it over to you, Betsy, for our closing.
Then this is Megan. I'm sorry. I don't know if
you're back.
I don't know if you heard my conversation. Somehow the phone just died. I'm not certain what's going on, but what I was trying to say was that I think a multidisciplinary approach, including the approach that we took today, including states and CHW allies and people from the federal sector as well as the state level is going to be needed to get us to the financing and reimbursement that we're looking for CHW. For me, that's a key takeaway, and I think it's critical. That's the way we started the forum, and I think that's a critical message to keep that in the front of our minds as we move forward. I'm sorry, I don't know why, but I got kicked off the phone, so I just wanted to say
okay.
that. Thank you.
Thank you very much. I would like to conclude our webinar for today, not before telling you, thanks to our participants. Thank you very much to our speakers. Thank you, Elaine, for doing the facilitation. Laura, for making and orchestrating all these webinars. Thank you very much to the FHI 360 team for all the support that we have been getting. And I have an announcement to make. The CHW Forum report, the first draft, has been developed. It's great. And right now it's in the middle of internal reviews. Once we finish that, I will keep my promise that the report will go to all of you so you can get the time to review and validate if what we listened is what you say and that was captured in the report. There is also going to be a job aid developed on what we learned from you all in the Community Health Worker Forum that will be shared with states, so you will have the opportunity to provide your feedback regarding that. Also, want to mention that please complete the feedback form, and also Laura will be sending an email after the webinar with the feedback form. Am I missing something, Laura?
No, Betsy, that's it. On the screen, you'll also see the information for the link to the feedback form. So as Betsy said, we would appreciate it if you would take the time to give us your feedback on today's webinar. And I'd also like to thank you all for your participation.
Well, thank you very much. I have a wonderful evening. Bye.
Bye-bye.
Thank you. Bye-bye.